Hello, everyone. This is Dr. Mickey recording a lecture on the anti-infectives, focusing on the drugs for bacterial infections in chapter 35. So the chapter begins with the differentiating the pathophysiology for the antibacterial agents or medications, goes over the difference between gram-negative versus gram-positive bacteria. And that's one of the gram-negative bacteria that are generally susceptible to the tetracyclines class medications, but they are resistant to the sulfonamide. And that has to do with the structure of the wall or the cell wall of the bacteria. And some bacteria has contain a thick cell wall composed of the peptidoglycan and retain the when you do the in the lab, like in the micro lab, one of the simplest methods of classifying microbes is to examine them macroscopically after a crystal violet gram stain has been applied to the microbes. And that's what you would apply to in order to differentiate between the gram positive versus gram negative bacteria. So when you do this kind of staining, the crystal violet gram stain, when you apply that to the microbes, so some bacteria will contain a thick cell wall composed of the peptidoglycan, and it will retain the violet color after staining. So these bacteria are called gram-positive bacteria. And these gram-positive bacteria includes this Staphylococcus, Streptococcus, Enterococcus. However, the bacteria that have a thin or thinner cell wall and they will lose the violet stain, they are called gram-negative bacteria. And examples of the gram-negative bacteria includes like bacteroids, Escherichia, Klebsiella, Pseudomonas, Salmonella. So the distinction between the gram-positive and gram-negative bacteria is profound, one that reflects important biochemical and physiological differences between these two groups. So many antibiotics are effective against only one of the two groups. And we give just an example of the beginning. We said that the gram-negative bacteria are generally like susceptible to the tetracycline class, but they are resistant to the sulfonamide class. That's the gram-negative bacteria. Just an example that the bacteria, either negative or positive, they will be susceptible to the one or more specific class of antibiotics or antibacterial agents. But this generalization, however, quickly will break down when the resistance strains would occur or develop. And we'll go over the resistance and why resistance, bacterial resistance will develop. And then we have a differentiation between also the exotoxin and the endotoxin, in which that the exotoxins, they are the proteins released by the bacteria into surrounding tissue that have the ability to inactivate or kill the host cells. However, the endotoxins, they are the non-protein chemicals that are harmful, non-protein chemicals that are part of the outer layer of the normal cell wall of the gram-negative bacteria. So after the bacterial death, after the bacterial cell dies, the endotoxins are going to be released and liberated into the surrounding tissue and will induce the macrophages to release large amount of cytokines, which are the chemical mediators. So we explained yesterday in the immune system or the inflammatory response, the normal flora as the first line of mechanism, how we have normal bacteria, good bacteria, and different areas of our body, especially like in the GI tract, and one of them is the normal flora, which is the bacteria that are provided with nutrients from digested food. And this slide provides all the details about the normal flora and the functions and how it's the mutual association or relationship between the normal flora and our body. And then we have something called opportunistic infections or microorganisms. These are the microorganisms that are able to become active when the immune system is competent and strong enough. These microorganisms are going to be living in harmony with the body, but not eliciting any infections or causing any infections. But when the immune system becomes immunocompromised and become compromised, that's when these microorganisms are going to cause infections, and that's is called opportunistic infections. So we have different classes of infectious microorganisms, including what we have in this slide, like bacteria, viruses, chlamydia, rickettsia, and others. And the stages of the infection start with colonization and ends with the spread. But in between, you have invasion, multiplication of the microorganism, either it's bacterial or viral or any other form of microorganism, and then the spread of that bacteria to other adjacent and distant areas. Then, now the factors for the infection, in terms of that, the infection by the pathogen is influenced by many factors. So many factors that will influence the speed of the infectious disease or the infection to occur, spread, invade other cells and tissues and organs. So the mechanism of action. It causes the disease in two ways, either through the invasiveness or production of the toxins. So through the invasiveness, it will divide rapidly to overcome and cause the direct damage to the cells and tissues. Production of toxins, very small amounts, disrupt the normal cell function. But that's through the production of toxins. Very small amount of this toxin will disrupt the normal cellular function. The infectivity of the microorganism, which is the ability of the pathogen to invade and multiply in the individual, in the cells and tissues and organs, and result in the infection. Pathogenicity, which is the ability of the pathogen to produce and cause the disease or the infection. Virulence, which is a very important concept here and factor that govern or influence the patho, the ability of the microorganism to cause the infection. What is the potency? How strong is that pathogen? Which is usually we measure the virulence as a potency of the pathogen in terms of the number of these microorganisms, how much we have, or how many cells, or how many microorganisms do we have, or how much toxins is available or required to kill the host and result in infection and cause the infection. Like measles, they have a very low virulence compared to rabies, which has a high virulence. So, which is, again, it's the ability of the microbe to produce disease when present in minute numbers, very small, tiny numbers. So measles has like very low virulence. The rabies have a high virulence. We measure the virulence also. For example, when you request a urinalysis and CNS culture and sensitivity test for urine, for example, when you do the CNS, you're looking for also virulence because the culture, it will provide you the result of the culture, analysis and results. You will receive it in terms of how many CFUs of that microorganism has been isolated, how many microorganisms has been isolated, and then for each one, how many cells do you have? How many CFUs is present? And so if it's more than 100,000, that's significant for diagnosing patients for UTI. That's an example of the virulence, how you apply virulence to the ability of the pathogen to cause the infection. Now, the bacteremia or septicemia, which is the presence of bacteria in the blood as a result of a failure of the body's defense mechanisms. So this is usually caused by, most likely by the gram-negative bacteria, in which the toxins released in the blood cause the release of vasoactive peptides and cytokines and chemical mediators that would produce a widespread of vasodilatation. And we explained about the entotoxins earlier, that these are the proteins released during bacterial growth, and they will induce also, they usually are enzymes that are going to induce the cytotoxins and other chemical mediators to be released, and which eventually is going to result also in the vasodilatation as well. The endotoxins, lipopolysaccharides, LPS, that are contained in the cell wall of the gram-negative bacteria and usually are released during the damage, breakdown, lysis, or destruction of the bacteria. And from micro class, you can refer to these kind of methods of describing bacteria as basic shapes, different shapes, ability to use oxygen like aerobic, anaerobic, rod shape or spiral shape, size of the wall, thick walls, thickness of the wall, gram-positive, thick walls, gram-negative, they have thin walls. Another slide differentiate between the gram-negative and gram-positive bacteria. Different forms of or pictures of the pathogens, different pathogens. The slides provide a description of the bacteria or the name of that microorganism, the disease that is going to result or caused by or results from the microorganism, and description of the specific disease being caused by that microorganism. Now, the fever as the process of resetting the set point of the hypothalamus due to the exogenous and endogenous pyrogens. We said anytime you will say pyrogen or you hear pyrogens, you will think of fever and hyperthermia, because these are the pyrogens that are responsible for raising or causing the set point at the hypothalamus to rise, and results in hyperthermia and fevers to spike. Now, the mechanism of fever, we said that with infection or some toxins from the bacteria, so the bacteria will release the biochemicals into the bloodstream. These are the exogenous pyrogens, which are the lipopolysaccharides, the LPS, of the gram-negative bacteria. they will signal the white blood cells, especially the monocytes and macrophages, to produce their own biochemicals. And then these biochemicals will be the endogenous pyrogenes, like the interleukins, interferons, prostaglandins. These are going to increase and elicit the first they will induce the synthesis of prostaglandins, and then they will cause the hypothalamus to raise its set point and lead to fever. So it's exogenous pyrogenes, the bacterial biochemicals, then it's going to produce their own toxins, which is the endogenous pyrogenes. Biochemicals like endogenous pyrogenes, which is the interleukin or interferons. These are the endogenous pyrogenes, interleukins, interferons, which will induce prostaglandins that will eventually raise the set point of the hypothalamus to cause fever. So that's the exact mechanism how fever will develop from the exogenous pyrogenes and the endogenous pyrogenes. Many infections are called fevers, like typhoid fever, rheumatic fever. Now, the shift to the left phenomena, this is a very important, significant concept in infectious disease and infections and sepsis and septicemia, because we have two different types of white blood cells. So we said we have the total white blood cells measured in thousands, and the differential white blood cells are measured in percentage. The result of, will be provided in percentage out of the total of the white blood cells. So the two different types of white blood cells in terms of the mature and immature, we have the bands and segs, which is segmented neutrophils. The bands are supposed to be between like 3 to 6%. That's the maximum. 6% of bands, which is the immature. The bands are immature neutrophils, and sometimes it's also called STABs, STABS, or RODS, RODS. However, most of the neutrophils are of the segmented or segs. They are mature cells. They comprise of between like 50 up to 62% of the total white blood cells. But the bands are immature, account for 3 to 6% of the white blood cells or leukocytes. So bands are immature, 3 to 6%. Segmented neutrophils or segs accounts for 50 up to 62% of the total white blood cells. So when the infection occurs, then the bone marrow, during the infection process, then the bone marrow is going to start to rapidly produce neutrophils because they are the body's main defense against bacterial infections, these neutrophils. So as large numbers of these neutrophils are released in the bloodstream, increasing numbers are immature bands. So an increase in the bands is the primary indicator of shift to the left phenomena or concept. So for example, with an acute infection, the white blood cell count may increase to 15,000. It's that normal, supposed to be between 5 to 10,000. During the infection, it may increase up to 15,000. The bands may go up to 10%, and the neutrophil up to 65%. And the other cells will total 25%. The other cells means eosinophil, basophil, lymphocytes, monocytes. all of these will account for 25%. But the most important thing is that the bands will go up, neutrophil segment will go up. But the downside to all of this is that the bands are going to be extremely present in the blood, more than 6%. They are immature neutrophil cells. But that's an indication that there is an infection, or it indicates the presence of infection. And that's shift to the left phenomena. This slide shows the mechanism of action of antimicrobial drugs on different types of or classes of medications, and how the meds are going to attack and target the bacteria at different stages and phases of the disease process, and the affects the or destroying the cell wall, or the inhibit the synthesis of cell wall, or like number 5, number 4, which it's a DNA synthesis inhibitors like fluoroquinolones. Number 1, like the RNA synthesis inhibitors like rifampin. So it's the antibacterial against the TB, for example, rifampin, one of the main medications or antibiotics for tuberculosis. Number 5, cell wall synthesis inhibitors like the carbapenems, the penem family, cephalosporins, isoniazid, penicillins, vancomycin. Number 2, protein synthesis inhibitors like aminoglycosides and other meds. Number 3, antimetabolites like sulfonamide. So the slide provides you just an overview of the different types of classes of medications, and how each class would target the bacteria or microorganism. So the anti-infective drugs, how it's different from the vaccines. The vaccines will, induce a long-lasting protective immune response that will not result in disease in the health recipient. So it's kind of protective to prevent the disease in healthy recipient. So this patient will receive attenuated organisms, or cold organisms, or recombinant, sometimes recombinant viral protein, bacterial antigens or toxins. So there's different types of vaccines, but they are more prophylactically protecting against the infection. When the patient becomes in contact with that, or individual becomes in contact with the microorganisms, they already have developed an immunity against that antigen or microorganism. So they have the immunity competent to prevent the infection. However, the antimicrobial or anti-infective drugs, they affect target organism, either its structure, the microorganism structure, or its metabolism, or its life cycle. And there's a difference between the antibiotics and bactericidal agents and the bacteriostatic agents. Antibiotics, that's medications or natural substances produced by bacteria that will kill other bacteria. However, the bactericidal, they are agents or drugs that are going to destroy the bacteria, and bacteriostatic, which is a slow agents that will slow the growth of the bacteria. So the 5 different mechanisms or specific mechanisms of how the antimicrobials, how anti-infectives or antibiotics are going to destroy the bacteria and treat the infections will be either to inhibit synthesis of cell wall, or damage the cytoplasm membrane, or change or alter the metabolism of nucleic acid, or inhibit protein synthesis or modify energy metabolism. So multiple resistance, why have multiple resistance microorganisms appear? Or like in the last, recently, we're seeing much of the of that multiple resistant microorganisms. Multiple resistance microorganisms have been appeared recently because of the overuse of antibiotic. The overuse of antibiotic can lead to the destruction of the normal flora, allowing the selective overgrowth of antibiotic-resistant strains or the pathogens that have been previously being kept under control. Like, for example, the clindamycin, in which that the normal intestinal flora became compromised, which will allow for the overgrowth of the C. diff. And that's what we, you are seeing much of that C. diff lately or recently. More of the C. diff cases because of that, which will result in the development of the pseudomonas membranous colitis. So the resistance also, the multiple resistance microorganisms will appear. There are other reasons and etiologies for that, which is what is called the antigenic variation. Either it's the antigenic mutations or recombination, or the antigenic, drift or shift or gene switching. But these are other reasons for the resistance. Acquired resistance. And that's will take place, this acquired resistance occurs when the pathogen develops the gene that will survive longer or grows very fast and quicker than normal. So either through maturation, the antibiotics will destroy sensitive bacteria. And the insensitive, mutated bacteria will remain, and mutated bacteria multiply with less competition. So there is no other bacteria to compete with. So the mutated bacteria will multiply with less competition. The mutations random and occur during cell division and may harm or help the bacteria. When the bacteria became mutated, so these mutated bacteria also they will multiply and increase in number. The antibiotics do not create mutations. The resistance not caused by, but is worsened by overprescription of antibiotics. So we know that, when there's overprescription of antibiotics, that will result in resistance, in which that there is results in a loss of antibiotic effectiveness. So we have to only prescribe when it's necessary to prescribe the antibiotics. Viral infections do not prescribe antibacterial drug medications. The long-term use of these antibiotics also may result in or increase the likelihood for resistant strains to develop. The prophylactic use appropriate in some cases to prevent the infection, like in dental procedure, for example, in patients who had underwent a prosthetic heart valve replacement procedure or CABG. With the prosthetic valve replacement, they need, anytime they go for dental procedures, they need prophylactic antibiotics to prevent the infection. Careful selection of control of the correct antibiotic essential. So we have the difference between the super infections and opportunistic infections. So first of all, to select the exact or effective or the appropriate antibiotic for that specific infection requires that you have to do some type of testing. You may start broad, like during the sepsis, septicemia, maybe you start with broad spectrum, but at the same time, before you start the antibiotic, you have to take, or draw a specimen, either blood culture, urine culture, if that's a wound, drainage culture, sputum culture. So you have to, because we have to do the CNS. In order to, we have to do culture and sensitivity testing. Thus, ideally, should be done first before you start the antibiotic. So you can isolate the bacteria or microorganism, identify one, if there is one or more of the microorganism, know what kind of microorganism is in the infected secretions or specimen, and then you can treat according to the result of that CNS. So culture is critical to isolate the bacteria or the microorganism, and the sensitivity test is critical to identify the microorganisms that are going to be resistant or going to respond to the infection, to the microorganism. And we can also limit the adverse effects if we do the CNS or select the appropriate and effective antibiotic. So we have broad spectrum antibiotics that will be effective for a wide variety of bacteria, and then the narrow spectrum, which is very effective to very narrow species or specific groups of bacteria. Now the CNS, we said it's an examination of specimen for microorganisms. It takes a couple of days to to finalize or to the final results of the CNS testing. You can do CNS for urine, for blood. You can do CNS for culture, for drainage from the wound. You can do it from from the sputum. So the super infections, they are secondary infections. They would occur when too many host flora are killed by the antibiotic. Host flora normally prevent the growth of pathogenic organisms. They are good bacteria. So the pathogenic microorganisms have a chance to multiply. So superinfections occur only during treatment with antimicrobial agents. The opportunistic infections, they take advantage of the suppressed immune system. Signs and symptoms include like diarrhea, bladder pain, painful urination, abdominal, vaginal discharge. So this opportunistic infections occur with immunosuppression. So that's the main differentiation between superinfections, which would occur only during the treatment with antimicrobial agents or drugs or antibiotics, versus the opportunistic infections, which usually occurs when or with the immunosuppression, when the immune system has become compromised or suppressed. These are different classes of antibiotics. So we'll start with the penicillins, the first class of antibiotics. So penicillins, the mechanism of action is to kill bacteria by disrupting their cell wall. Disruption of the cell wall of the bacteria will result in the death of the microorganisms of the bacteria, and that's how the penicillin will treat bacterial infections as more effective on the gram-positive bacteria. There is a beta-lactamase ring in their structure, in the structure of the penicillin, which is the portion of the chemical structure of penicillin that is responsible for its antibacterial activity. The beta-lactamase family also includes cephalosporins, aztreonam, imipenem, meropenem, and ertapenem, which is the penem family and the cephalosporin. You can't just say cephalosporins and the penem family, because that's the suffix for all the penems. So it's very effective for meningitis, skin, bone, and joint infections, stomach infections, blood and valve infections, gas gangrene, tetanus, anthrax, sickle cell anemia in infants. The principal adverse effect is the allergic reaction. So that's why it's very, it's really important, imperative that we have to test for the allergic reaction, or if the patient is allergic to the drug, by doing the test or allergy test prior to starting the patient on the medication. The prototype drug for the penicillin is the penicillin G, which is the antibacterial. It's very similar to the penicillin V. So the penicillin G, that's drug of choice against the streptococci, pneumococci, staphylococci organisms, because these do not produce it, or do not produce beta-lactamase, and shown to be susceptible by CNS testing. So only 15 to 30% of the oral dose of the penicillin G is absorbed. So because of its low oral absorption, the penicillin G is often given by the IV or IM routes. So you can give the penicillin G either intravenous or intramuscular. Penicillin V, and amoxicillin are more stable in acid and are used when the oral penicillin therapy is desired. Now, the penicillinase producing organisms, there are organisms that produce penicillinase, which is the enzyme that's going to destroy the beta-lactamase ring, the ring that kind of strengthen the penicillin. So the penicillin-producing organisms, they inactivate both penicillin G and penicillin V. So these type of organisms that are able to produce this penicillinase, they can destroy both types, penicillin V and penicillin V and G. So the penicillin G antibacterial, it's cell wall inhibitor or natural penicillin. The we do not mix the penicillin and aminoglycosides in the same IV solution. We give IV medications like 1 hour apart to prevent the interactions because they will interact with each other. The penicillin G, in terms of adverse effects, the penicillin G has fewer serious adverse effects than V. It may cause diarrhea, nausea, vomiting, like GI symptoms. These are the most common adverse effects. And it can be more serious in children and older adults. Other adverse effects would be the pain at the injection site. Super infections are possible. And we said that the super infections, what are they? They are secondary infections, and they will occur when too many host bacteria are killed by the antibiotics. So the super infections occur only during the treatment with antimicrobial or antibiotic drugs. And the anaphylaxis, which is the most serious side effect. While most allergic reactions to penicillin occur within minutes after administration, within minutes, the patient may develop the allergic reaction against the penicillin late. Sometimes patients develop what is called the late hypersensitivity reaction, like several weeks after receiving the penicillin. Has been shown in certain, in few cases, but that could happen. The late reaction to penicillin. But usually in general, that usually takes, will develop within minutes from the onset or from the, receiving the penicillin. So it's the least toxic against, the least toxic of all antibiotics. And penicillin, or penicillins, all penicillins are the most common cause of drug allergy. So the contraindication, the only contraindication is the hypersensitivity to the drug, which is to the penicillin class, in which that the drug is extensively is going to be excreted by the kidneys. So the drug should be used with caution in patients with renal disease, especially with severe kidney injury or kidney disease, like a CKD or interstitial disease or any severe kidney injury or infections, in which the renal function test has significantly declined. Penicillin G may decrease the effectiveness of the oral contraceptives. The potassium-sparing diuretics may cause hyperkalemia when administered with penicillin G, especially penicillin G potassium. And because the penicillin, all penicillins, they can antagonize the actions of the aminoglycoside antibiotics, the drugs from these two classes should not be administered concurrently, should not be administered at the same time, simultaneously, or concurrently. So we have to administer one, at least 1 hour apart. Thirdly, graph shows the penicillin levels of penicillin G following the IM injections of 3 different penicillin G salts. Penicillin G, which is potassium penicillin, procaine penicillin, and benzathine penicillin. 3 main mechanisms, the mechanism for bacterial resistance, but 3 main factors would explain the mechanism of bacterial resistance. So it's either the inability of the penicillins to reach their target, that's why there is resistance, or because of the inactivation of penicillins by bacterial enzymes, or because of the production of penicillin binding proteins, PBPs, which have the low affinity for penicillins. So the inactivation of the penicillin by bacterial enzymes. So penicillinase, which is a beta-lactamase, the enzymes that will render penicillin inactive. And the bacteria can produce a large variety of these enzymes specific for penicillins. And then we have the ESBL, which is extended species of beta-lactamase. And you will find that, in the mid-surgeoness, certain patients, they would have the ESBL type of bacterial resistance. Mostly you find it either in the urine. Most of the cases I've been seeing, where, been experiencing or seeing cases of ESBL in the urine, and sometimes in the other, blood or drainage or wounds, but most of the cases are ESBL in the urine. That's type of bacterial resistance. So you would assess for the penicillin allergy in each patient who will receive the penicillin. Any patient receiving penicillin should be tested for the allergy to penicillin. If a history of mild reaction, you would consider the cephalosporin. If a history of anaphylaxis, then avoid administering penicillin or cephalosporins at all. The immediate reaction would result in 2 to 30 minutes. Like it will start beginning 2 minutes up to 30 minutes from the injection or from receiving the drug. That's immediate. Accelerated would be like within like a minute. It takes up to 72 hours, but it could elicit or begin in 1 minute. Late, that's a reaction takes days and sometimes weeks to develop. Patients with the anaphylaxis or anaphylactic shock due to receiving the insulin, they are allergic to penicillin, and they are allergic to the penicillin. Anaphylaxis means there is laryngeal edema, bronchoconstriction, bronchospasm, difficult breathing, severe hypotension. And that's from the allergic reaction. And that's from the immunoglobulin type E that's going to result in massive vasodilatation. That's why there is hypotension. We would treat that with epinephrine, respiratory support, like mechanical ventilation support, MVS. And we can prevent it by doing the allergy test. The MRCA, also another form of the resistance, which is the methicillin-resistant Staphylococcus aureus, MRCA. The broad spectrum antibiotics, we have prototype, which is ampicillin. Drug similar to the ampicillin is the amoxicillin. The beta-lactamase inhibitors, which is the drug going to be added to the drug to protect the beta-lactamase. I remember that we said that bacteria, they will produce the enzyme that's going to destroy the beta-lactamase ring. So these are the substances and chemicals that are responsible for maintaining the structure of the beta-lactamase ring. Like clavulanic acid, tazobactam, sulbactam, they'll be added to the antibiotic. Like, for example, we have unicin, adding the sulbactam to the ampicillin, or augmentin, adding the clavulanic acid to the amoxicillin to protect the beta-lactamase ring. So these are the beta-lactamase inhibitors, or in other words, that to protect the beta-lactam ring and inhibit the lactamase, which is the enzyme that will destroy the ring, beta-lactamase inhibitors. We have also the piperacillin added to the tazobactam, which is Zosyn, very common drug in treating the infections. And Zosyn comes in different dosages, and Zosyn runs over usually 4 hours, IV intravenously. So drugs that would weaken the bacterial cell wall, like cephalosporins, the penims, vancomycin, aztreonam, and others, most widely used groups of antibiotics. Among all the antibiotics, they are beta-lactam antibiotics. They're similar to the penicillin structure. They are bactericidal and usually given parenteral, intravenously, and the toxicity is very low. So they bind to the penicillin binding proteins, disrupting the cell wall synthesis and cause cell lysis, which is breakdown or death of the microorganisms or bacteria. Cefazolin, which is the like Ancef, that's the prototype drug for this group. So cefazolin is the beta-lactam antibiotic used to treat and for treatment and prophylaxis of bacterial infections. Treatment and prophylaxis of bacterial infections, especially the infections has been caused or are caused by these gram-positive organisms. So the cefazolin has been used to treat infections of the respiratory system, urinary system, like UTIs, skin infections, biliary tract, like the gallbladder infections, common bile duct infections, cystic duct infections. That's the biliary tract infections, bone infections, joint infections. And also has been useful in the pharmacotherapy of genital infections, septicemia, endocarditis. But cefazolin is not in effective to treat patients with or cases or against the MRCA, the MRSA. It's not effective for or against MRSA. So the drug is sometimes used for infection prophylaxis in patients who are undergoing surgical procedures. Cefazolin has a longer half-life than other first-generation cephalosporins, which allows for less frequent dosing. You can give just cefazolin just once a day. And it's one of the most frequently prescribed parenteral antibiotic. It's given IM. We said it should be given parenterally, parenteral injection, I mean, either IM or IV. So when you give ANCEF IM, it should be given deep into a large muscle to prevent injury to surrounding tissues. So the cephalosporins are well tolerated by most patients. Rash and diarrhea are the most common adverse effect, and superinfections are likely when the antibiotic is used for a prolonged period. Approximately 1 to 4% of patients will experience some kind of an allergic reaction. Severe hypersensitivity reactions are rare, although potentially fatal, and could result in death. When it's given IM, as an IM injection, pain and phlebitis can occur at the IM injection sites. The only contraindication was indicated this earlier is that the only contraindication is the hypersensitivity to cephalosporins or penicillins, because the cefazolin is extensively excreted by the kidneys. So the drug should be used with caution in patients with kidney disease, especially chronic kidney disease, CKD. Now, the drug-drug interaction, concurrent use of cefazolin with nephrotoxic drugs such as aminoglycosides or vancomycin would increase the risk of nephrotoxicity. Cefazolin may have additive or synergistic antimicrobial action with other antibiotics such as aztreonam, carbapenems, and the penicillins. The anticoagulant effect of heparin and warfarin may be increased if given concurrently with cefazolin. So if you give the heparin or warfarin sodium with cefazolin, make sure that you adjust the dosage based on the lab values. Either it's PTT or PTINR. PTT for heparin and PTINR for Coumadin, because the anticoagulant effect of the heparin and warfarin may increase if given concurrently with cefazolin. So we have first, second, third, fourth generation of this class of antibiotics. Cefazolin has been one of the widely prescribed as a first generation. Cephalexin, another one, Caflex, brand name. Second generation, we have Cefaclor and cefuroxime, which is Ceften or Zinacef. Third generation, we have an example of this, ceftazidime, which is the Fortaz, and ceftriaxone or Cefen. fourth generation cefepime maxipime. And then we have the fifth generation, which is the ceftaroline. So the first, and just to highlight a few things from this slide, is that the first and second generations are rarely used for active infections. Usually it's given for, prescribed for prophylactically, not for active infections, prophylactically, to prevent the infection, the first and second generations. The third generation is usually its preferred therapy for severe or for and severe and many infections, and highly effective and active against the gram-negative organisms. And they are able to penetrate the CSF fluid. The fourth and fifth generations that are usually effective against organisms that have developed resistance to earlier cephalosporins. So patient has been, or there is a resistance to cephalosporins, then, we would prescribe the fourth and fifth generation cephalosporins. And for example, the maxipime or cefepime as a fourth generation agent, like cefepime, are capable of entering the CSF to treat central nervous system infections, like meningitis, for example. Recyclins, the mechanism of action effective against broad range of gram-positive and gram-negative organisms, bacteria. And the adverse effects, super infections and other GI symptoms. And we'll talk about also the discoloration of the teeth and photosensitivity from the use of the tetracycline. So the tetracycline, we have 4 members of tetracycline family available for systemic therapy. So diclomycin or dimeclocycline used to treat the excess ADH hormone secretion, and that's in order to increase diuresis. And that's in the SIADH hormone, syndrome of inappropriate ADH hormone, antidiuretic hormone. That's SIADH. That's an endocrine disease affecting the pituitary gland. Posterior lobe of the pituitary gland results in SIADH. And that would be a treatment for the SIADH to increase diuresis, because patients with the SIADH, they will retain fluids. Doxycycline, which is a effective treatment or antibiotic for STDs. The doxycycline is a widely prescribed drug due to its high safety profile and is well absorbed with or without food, which is the user-friendly feature. Patients can take it either on empty or full stomach, and it can be taken orally daily, which would increase adherence once it's, when it's once daily, and it's not like 3 or 4 times a day. Once daily is always preferable for patients because that will increase adherence and compliance with the drug regimen. I mean, tetracycline also is effective against many infections like Lyme disease, anthrax, H. pylori, acne, peptic ulcer disease, periodontal disease, or infections. Actions and uses of tetracycline. So tetracycline is effective against broad range of gram-positive and gram-negative organisms. Chlamydia, rickettsia, mycoplasma. Its use has increased over the past decade due to its effectiveness against the H. pylori in the treatment of peptic ulcer disease. We can give tetracycline PO orally, although it has a short half-life that may require administration 4 times per day. There is also a topical and oral preparations to treat acne. We have an IM preparation as well. It's available. However, the IM can cause intense pain at the injection site. So tetracycline is a broad-spectrum antibiotic. It inhibits the protein synthesis, and it would increase the bacterial resistance. The bacterial resistance has emerged in large amounts or numbers. In other words, there is increasing bacterial resistance has been emerged recently. So I've seen many cases of resistant to bacteria that is resistant to the tetracyclines. So we have to administer the oral drug with a full glass of water to decrease esophageal and GI irritation. We administer the antacids and tetracyclines 1 to 3 hours apart because of the interaction. The adverse effects. Being a broad-spectrum antibiotic, tetracycline has a tendency to affect the vaginal, oral, and intestinal flora and cause superinfections. Tetracyclines irritate the GI mucosa and may cause nausea, vomiting, epigastric burning, and diarrhea. Diarrhea may be severe enough to cause discontinuation of therapy. Other common side effects of tetracycline would include the discoloration of the teeth and photosensitivity. So there is a list of some listing here of the adverse effects, like a GI irritation, effect on bone and teeth, which is discoloration, superinfection, hepatotoxicity, renal toxicity, and photosensitivity. So contraindications. Tetracycline is contraindicated in patients with hypersensitivity to the drug or any drug in this class. So the drug should not be used during the second half of the pregnancy. In children 8 years or younger, and in patients with severe renal or hepatic impairment. Drug-drug interaction. Milk products, iron supplements, magnesium-containing laxative, antacids, all will reduce the absorption and serum levels of tetracyclines. Tetracycline binds with the lipid-lowering drugs like cholestyramine, questran, which will decrease the antibiotic absorption. This drug also will decrease the effectiveness of the oral contraceptives. So the calcium supplements, milk products, iron supplements, magnesium-containing laxatives, and most antacids, they will reduce the absorption of the drug. So since the absorption of the tetracycline decreased if given with these drugs or medications or supplements, then it shouldn't be given concurrently. There should be at least 1 to 3 hours apart between them. Macrolides. Macrolides inhibit the protein synthesis by binding to the bacterial ribosome, effective against most gram-positive and many gram-negative bacteria. They're effective against the streptococcus infections or infections caused by the streptococcus bacteria, flu, or the H. influenza, and the Mycoplasma pneumoniae. Erythromycin is the prototype drug for this group, for the macrolide. We have a clarithromycin, other medications or other macrolides, clarithromycin, lacbioxin, azithromycin, which is very effective and for like pneumonia or respiratory tract infections. Azithromycin, it has an extended half-life and usually administered for 5 days instead of 10 days. So we have like something called a Z-pack. Azithromycin of 5 tablets, 2 tablets given the first day, like a loading dose, 250 milligrams, 2 tablets in the first dose, and then once daily. The other 3 tablets will be given once daily. The azithromycin is commonly prescribed. It is very popular due to its dosing, which would increase adherence once daily. And also it causes a few GI effects or side effects. The erythromycin. Erythromycin is inactivated by stomach, so that's the actions it uses, is that the erythromycin is inactivated by the stomach acid and is thus formulated as coated acid-resistant tablets or capsules, in which that will dissolve in the small intestine. So its main application is for patients who are unable to tolerate the penicillins or who may have penicillin-resistant infection. And it has a spectrum very similar to that one of the penicillins, and is effective against most gram-positive bacteria. And it's sometimes used to treat susceptible infections by the pertussis, like whooping cough, whooping cough, which is the exact name as the Portadilla pertussis, but that's a whooping cough. And the Mycobacterium pneumoniae and diphtheria. So these are the administration alerts or like nursing implications. Very important that you administer the oral drug on an empty stomach with a full glass of water to prevent the irritation. Because the suspension, always, any suspension, you have to shake the bottle thoroughly to ensure that the drug is well mixed and you give the exact consistency and strength of the drug. Otherwise, the drug will precipitate in the bottom of the bottle, and then when you not mixing or shaking the drug is going to result in that the drug in the bottom and then the solvent in the top. So you are giving more, few days you're giving the solvent, and then the later days you're giving the concentrated drug. So that will alter and change the concentration of the drug in the blood, which make it ineffective on the earlier days and maybe toxic to the, towards the end of the later days. So shaking the bottle is very important for that reason. The most frequent adverse effect from the erythromycins includes nausea, abdominal cramping, and vomiting, more of GI symptoms. Although these are rarely occurred or rarely serious enough to cause the discontinuation of the therapy. Usually, patients will tolerate, these symptoms, and it doesn't usually result in the drug to be discontinued. So patients will tolerate these symptoms and will keep taking the drugs. Concurrent administration with food would reduce these symptoms. So eating or taking the drug on a full on a full stomach, or after with food, or that will eliminate and will reduce these symptoms or side effects. Hearing loss, vertigo, dizziness may be experienced when using high doses of this drug, particularly in older adults and those with impaired hepatic or renal excretion. The high doses of erythromycin may be cardiotoxic and would predispose the patient or put them into a risk for fatal or life-threatening dysrhythmias. Aminoglycosides. Aminoglycosides, they inhibit bacterial protein synthesis. And primarily, they are prescribed for the treatment of serious systemic infections caused by aerobic gram-negative bacteria, mycobacteria, and some protozoa. Gentamicin is the prototype drug for this class. Other similar drugs to within the aminoglycoside group or class is amikacin, neomycin, streptomycin, and tropomycin. So you can go with the suffix of mycin or ACIN or YCIN to indicate or to remember the aminoglycosides. So the gentamicin is a broad spectrum bactericidal antibiotic, usually prescribed for serious urinary like UTIs, respiratory like upper respiratory tract infections, the nervous system, or GI infections, when less toxic antibiotics are contraindicated. Very effective against the Enterobacter, the E. coli, Klebsiella, Citrobacter, Pseudomonas, Serratia. So gentamicin is effective against a few gram-positive bacteria, including some strains of MRSA. It may be given concurrently with penicillins or cephalosporins to improve bacterial kill and to delay the resistance. You can have more effectiveness to kill more bacteria and delay resistance if we combine the drug with the gentamicin with concurrently given with the penicillins or cephalosporins. We can kill more bacteria, destroy more bacteria, and we can delay the resistance. And this drug is now absorbed by the oral route. So always gentamicin or aminoglycosides given parenteral. We have also topical formulation that is available for the infections of the external eye, ophthalmic, topical formulation of the gentamicin. But in general, it's not usually absorbed by the oral route. So this drug is used to treat aerobic gram-negative bacilli, used to treat serious infections caused by aerobic gram-negative bacilli like Pseudomonas, E. coli, Klebsiella. So for the IM administration injections, inject deep into a large muscle. Use only IM and IV drug solutions that are clear and colorless or slightly yellow. Discard any discolored solutions or those that contain any particulate matter. So the adverse effects of the gentamicin, the first main adverse effects is going to be otorenal toxicity, toxicity to the ear and kidneys. So the adverse effects include rash, nausea, vomiting, fatigue. These are the most frequent adverse effects. The most serious are the otorenal toxicity. As with other aminoglycosides, certain adverse effects may be severe. And there is an increasing resistance to the gentamicin has been shown lately. And some cross-resistance among aminoglycosides has been reported as well. So the neurotoxicity, in which that the neurotoxicity may manifest as the ototoxicity and produce a loss of the hearing or balance, which may become permanent with continued use, which means long-term use of the gentamicin may result in a permanent hearing loss, tinnitus, vertigo, persistent headaches, or early signs of ototoxicity. So the risk of the neurologic effect is higher in patients with chronic kidney disease. Other signs of neurotoxicity would include paresthesia, tingling sensation, numbness, muscle twitching, seizures, and the concurrent use with other neurotoxic drug should be avoided. The neuromuscular blockade and respiratory paralysis are possible, and the drug may cause severe neuromuscular weakness that may last for several days. Nephrotoxicity, that's also a possible side effect. Signs of reduced renal function or kidney function would include oliguria, proteinuria, and elevated bone and creatinine levels. Nephrotoxicity is it has particular concern to patients with pre-existing CKD or chronic kidney disease and may limit the pharmacotherapy. And again, the concurrent use with other nephrotoxic drugs should be avoided. Contraindications, the gentamicin is contraindicated in patients with hypersensitivity to drugs in the aminoglycoside class. Drug therapy must be monitored carefully in patients with impaired renal function or patients or those with pre-existing hearing loss. The drug-drug interaction, the risk of the ototoxicity would increase in the patient who is currently taking the amphotericin B, furosemide, aspirin, bumetanide, Bumix, cisplatin, and other medications. So concurrent use with amphotericin B and other and the other medications would increase the risk of nephrotoxicity. So there are certain medications that would increase the risk of, for ototoxicity, and other medications like the amphotericin B, capreomycin, cisplatin, polymyxin B, or vancomycin. These will also increase the risk of nephrotoxicity. So there are, in other words, that we shouldn't be given or prescribing the gentamicin concurrently with amphotericin B, furosemide, aspirin, bumetanide, or cisplatin, because they will increase the risk for ototoxicity. Same thing, we should not be concurrently prescribing or using the gentamicin with amphotericin B, cisplatin, or vancomycin, because that will increase another toxicity, which is the nephrotoxicity. So remember that vancomycin is a nephrotoxic drug, as well as the gentamicin. So gentamicin serum levels, single large dose each day or 2 to 3 smaller doses. So we have to monitor the serum levels, and the same dose or the same aminoglycoside dose can produce very different plasma level in different patients. So it's very individualized when it comes to the prescription of the gentamicin. So we have two different levels. We have something called peak and trough. The gentamicin peak half to 1 hour after IM administration or 30 minutes after the completion of IV infusion. Trough level should be drawn just before the next IM or IV scheduled dose. So this graph shows the plasma gentamicin levels produced with once daily doses versus divided doses. The curves depict the plasma levels of the gentamicin produced with the first, which is a single large dose administered once a day, versus in two, which is the same daily total given as 3 smaller doses spaced 8 hours apart. The plasma levels with both regimens are high enough to produce good bactericidal effect. Now, the shaded area indicates levels that are low enough to permit the washout and the release of the drug from the vulnerable cells in the inner ear. So remember that the once daily dosing that the levels are in the washout range for over 12 hours versus a total only 6 hours when divided doses are used. As a result, the ototoxicity is lower when the once a day schedule. So once a day schedule is going to result in less ototoxicity would result if we prescribe the or adopt the once a day schedule. Next is the fluoroquinolones, which is drugs that are going to inhibit bacterial DNA synthesis by inhibiting the DNA gyrase and topoisomerase IV. Now, the drugs have been discovered that inhibit the different steps in bacterial DNA application. Now, these fluoroquinolones are antibiotics whose therapeutic application have expanded in recent years to treat different type of infections caused by gram-positive and gram-negative bacteria. So the drug will disrupt the DNA replication and the cell division. It can be fluoroquinolones are available as a PO, can be administered PO oral or IV medications. We have also an ophthalmic drops, which is the Zymar. What would be the primary use of the fluoroquinolones would be of the respiratory infections, GI, GU infections, skin, soft tissue infections, UTIs, uncomplicated UTIs, prophylaxis of the anthrax infection, and the adverse effects would be, or side effects would be, the GI symptoms like nausea, vomiting, diarrhea, and sleep disturbances, headache, dizziness. Maybe also result in hepatotoxicity and dysrhythmias. So ciprofloxacin. So floxacin is the suffix for the fluoroquinolones. Fluoroquinolones, the suffix is going to be floxacin, ciprofloxacin, levofloxacin. So floxacin is the suffix for fluoroquinolones. So they're antibacterial. They will destroy or inhibit the bacterial DNA synthesis. That's their mechanism of action. The ciprofloxacin is the second generation fluoroquinolone that is most widely prescribed drug in this class. It inhibits the bacterial DNA garase. The cipro affects the bacterial replication and the DNA repair. More effective against the gram-negative than gram-positive bacteria. And it's prescribed for UTI, sinusitis, pneumonia, skin, bone and joint infections, infectious diarrhea, and certain eye infections. The drug is rapidly absorbed after the PO administration and will be distributed to the most of body tissues. So it's a broad spectrum antibiotic, gram-negative and some gram-positive against this type of bacteria, gram-negative and more, and some gram-positive, but mostly gram-negative. So the drug of choice for the anthrax. The adverse effects of the drug So before we get to the adverse effects, we just go highlight a few things about the cipro or ciprofloxacin. Is that ciprofloxacin is well tolerated by most patients, and serious adverse effects are unknown. So when it comes to the adverse effects, is that usually it's well tolerated by most patients. Some patients will develop like GI, so GI toxicity. Some will develop like nausea, vomiting, diarrhea. That's usually may occur in about 20% of patients. So if ciprofloxacin is administered with food, we can diminish the adverse GI effects. We don't recommend that in a patient taking take the drug with antacids or with mineral supplements. So the patient should not take this drug with antacids or mineral supplements because the drug absorption will be diminished when it's taken with antacids or with mineral supplements. Some patients may report phototoxicity, headache, dizziness. So The first main side effects is going to be the cartilage toxicity, like the tendon rupture, tendonitis, rupture of the shoulder, hands, and Achilles tendon down the foot by the ankle. So avoid prescribing this drug in patients younger than 18 years old because of that cartilage toxicity, potential or possible cartilage toxicity. The GI toxicity, nausea, vomiting, diarrhea, or abdominal pain. CNS toxicity, dizziness, headache, restlessness, confusion, and sometimes are very rare, but seizures. Also, you can include the photosensitivity, hepatotoxicity, and resistance. And in elderly patients, we don't usually recommend the fluoroquinolones in older adults especially because of the cartilage toxicity and tendinitis and confusion, somnolence, which has become like kind of lethargic, psychosis, and visual disturbances. So the drug is contraindicated in patients with hypersensitivity to the drug within that fluoroquinolones class. And also we have to be careful when we prescribe the fluoroquinolones, especially Cipro, to patients with myasthenia gravis, because that's part of the black box warning that may cause extreme muscle weakness in patients with myasthenia gravis. And in terms of contraindication, it's contraindicated in patients with hypersensitivity to the drug. And the drug should be discontinued if the patient experiences pain or inflammation of the tendon because tendon rupture have been reported, because that's a sign of severe tendonitis, especially with the older adult population. Now, drug-drug interaction, concurrent administration with warfarin may increase anticoagulant effect and result in hemorrhage, bleeding. Antacids, iron salts, sucralfate, chlorphate, these would decrease the absorption of the ciprofloxacin. Antacids, iron salts, and sucralfate, they decrease the effectiveness and absorption of the ciprofloxacin. There was Alzheimer medication we indicated earlier that in 2006, which is the gatifloxacin, which is Zymar brand name. That's in 2006, the manufacturer discontinued the distribution of the oral and IV form of the drug, but it's still available in the market as an ophthalmic solution for bacterial conjunctivitis. We have other two forms of the fluoroquinolones, which is levofloxacin and moxifloxacin, Levaquin and Avelox. We have another like 4 different types of fluoroquinolones, but they are not quite widely prescribed, but these are the 2 most widely prescribed and widely prescribed medications from this group. Sulfonamides, the mechanism of action is to suppress the bacterial growth by inhibiting bacterial synthesis of folic acid. The primary use is for UTIs, urinary tract infections, pneumocystis carinii pneumonia, PCP, shingles or shingilla infections. Sorry, it's the shigella infections of the small bowel. It's different than the shingles, but this is shigella infections of small bowel. Because shingles is the herpes zoster, that's a different infection. This is of the shigella of the small intestine, or shigella infections of small bowel. The adverse effects, formulation of the crystals in the urine. So that's when we see sulfonamide, we always say take or encourage patients to drink enough fluids, water, so we can prevent the kidney stones. Because the adverse effect of the drug is formation or formulation of crystals in the urine, high tendency to develop kidney stones. Hypersensitivity reactions, nausea, vomiting, and serious side effects like agranulocytosis, acute hemolytic anemia, and aplastic anemia. So the actions and uses, the fixed dose combination of the sulfamethoxazole. So this is the prototype drug for the sulfonamide, which is a trimethoprim sulfamethoxazole, which is Bactrim or Septrim brand name. But it's the combination of two medications, trimethoprim and sulfamethoxazole. So the fixed dose of the combination of the sulfamethoxazole with the anti-infective trimethoprim is most frequently prescribed for treating patients with a UTI. It also has been approved to treat the PCP, pneumocystis carinii pneumonia, and sometimes patients with HIV/AIDS, they develop this type of PCP, pneumocystis carinii pneumonia. And now the new name for this pneumonia is pneumocystis jirovecii pneumonia, but it still has the same abbreviation as PCP. But it's one of the complications that HIV/AIDS patients may develop. And this drug is going to be very effective to treat the PCP. Also, the drug is effective to treat Shigella infections of the small bowel and the acute episode of chronic bronchitis. And we have the drug, the trimethoprim sulfamethoxazole, available as an oral and IV preparations. And we have also an oral normal strength and double strength of the drug. So both the sulfamethoxazole and the trimethoprim, they are inhibitors of the bacterial metabolism of the folic acid. So that's kind of provide a synergistic effect. So the reaction is synergistic. A greater bacterial kill is achieved by fixed combination than would be achieved with either drug used separately. So because humans obtain the precursors of folate in their diets and can use the performed folate, these medications are selective for bacterial metabolism. And another advantage of the combination is that the development of resistance is lower than is observed when either of the agents or medications is used alone. So we can lower the resistance when we combine both medications together. So more effectiveness and less resistance. synergistic effect or effectiveness, and less resistance as well. So we said administer the drug with a full glass of water to prevent the formation of crystals and kidney stones. So nausea and vomiting are the most frequent adverse effect of this drug, and the trimethoprim sulfamethoxazole or Bactrim. The hypersensitivity is relatively common and usually manifests as skin rash, itching, and fever. And so this drug should be cautiously used in patients with chronic kidney disease because of the crystalluria, oliguria, and renal failure, which have been reported. Periodic lab evaluation of the blood is usually performed so we can identify early signs or manifestations of agranulocytosis or thrombocytopenia. And due to the potential for photosensitivity, the patient should avoid direct sunlight during therapy. Now, the contraindications, the trimethoprim sulfamethoxazole is contraindicated in patients with hypersensitivity to drugs in the sulfonamide class. So any drug that has or includes the sulfonamide or sulfa, patient and allergic or sensitive or allergic to the drug, so patient should not receive the drug as long as the patient is allergic to sulfa. So it's contraindicated in patients with hypersensitivity to drugs in the sulfonamide class, patients with documented megaloblastic anemia due to folate deficiency should not receive this drug. Pregnant women at term and nursing mothers during lactation should not take this drug because sulfonamides may cross the placenta and are excreted in milk and may cause pernectasis, which is high bilirubin in babies. Trimethoprim decreases potassium excretion and should be used with caution in patients with hyperkalemia. A drug-drug interaction. Trimethoprim sulfamethoxazole may enhance the effect of certain anticoagulants. Enhancement of the effectiveness of the anticoagulant resulting in serious or life-threatening interactions. In other words, may lead to bleeding. So these drugs may also increase methotrexate toxicity. Patients on immunosuppressive agents like methotrexate, these drugs may also increase the methotrexate toxicity. Also, it may cause phenytoin dilantin toxicity because that drug decreases the hepatic metabolism of the phenytoin. So this drug, the trimethoprim sulfamethoxazole, may cause phenytoin toxicity. And same thing with the potassium, because this drug excretes potassium sparing effect on the nephron and should be used with caution in potassium sparing diuretics like spironolactone to prevent hyperkalemia. These are the specific infections that are the different types of UTIs, urinary tract infections, most common infections. Like in sexually active young women, 25 to 35% would develop at least one episode of UTI annual. And then in elderly women in nursing homes, they 30% up to 50% would have bacteria at any given time, and UTI is less frequent in males, and occurrence likely associated with the complications like septicemia or pyelonephritis or kidney stones or urolithiasis. The UTI can be complicated or uncomplicated. Organisms that cause the UTI. About 80% of the UTIs are uncomplicated community-acquired UTIs. And the most common bacteria is the E. coli, would cause the UTIs. And there's also a hospital-acquired UTI frequently caused by the Klebsiella, Proteus, Enterobacter, Pseudomonas, Staphylococcus, Enterococci, or ESBL, and E. coli. So the drug therapy to treat the UTIs, we mentioned earlier that the trimethoprim sulfamethoxazole, that's a treatment choice for oral therapy of UTI. So these slides, few slides will go over the description of the different types of UTIs, like upper and lower UTI infections, like acute cystitis, what are the symptoms, acute uncomplicated pyelonephritis, in which that would result in systemic. The acute pyelonephritis includes systemic manifestations like fever, chills, severe flank pain, dysuria, urinary frequency and urgency, and pyuria, which is like a posse drainage. And we said that the E. coli is the causative organism in 90% of community-acquired UTIs. Complicated UTI, males and females with structural or functional abnormality of urinary tract, like PPH, prostate hypertrophy of the benign prostate hypertrophy, renal calculi, kidney stones, and other kidney or renal problems, or even the indwelling catheter, polycatheter, when it stays for longer periods of time, that can result in complicated UTI. And we have recurrent UTI, in which that the relapse, about 20% recolonization with the original infecting organism, suggests the structural abnormality of the urinary tract, involvement of the kidneys, or chronic bacterial prostatitis, infection of the prostate gland, reinfection. 80% of recurrent UTIs in females, and usually involves lower UTI and may be related to the sexual intercourse. Acute bacterial prostatitis, which is the inflammation of the prostate caused by local bacterial infection. In which it will respond very well to antimicrobial therapy. So sulfonamides are the traditional drugs of choice for UTIs, but resistance limits their usefulness. So for a class, first, drugs available for systemic treatment of bacterial infections, more effective and less toxic drug that is now available for UTIs. The drug would inhibit the synthesis of the folic acid, the folate. The side effect is of the sulfonamides would be hypersensitivity reactions, hematologic effect for nectarus, like the increased level of the bilirubin, renal damage from dextrostyluria. The urinary tract antiseptics, these are anti-infective drugs used exclusively for UTIs. We can also include the CAM therapy, complementary and alternative therapy, like the cranberry, for example, because the cranberry, either it's capsules or crushed in powder, packed in like capsules, or even cranberry juice. The cranberry contains a significant amount of vitamin C and other antioxidants that which can promote the health and prevent the UTI, because the cranberry would prevent the splitting of the bacteria, and that will result in preventing the bacteria to stick to the wall of the bladder, and it will decrease the likelihood or the susceptibility to develop the UTI. That's the effectiveness of the cranberry, either it's juice or powder in a capsule. So it's because it prevents the bacteria from sticking to the wall of the bladder, prevents the splitting and the sticking to the bladder. So it will allow for a washing out of the bacteria and the urine. That's the effectiveness of the cranberry. Nitrofurantoin, that's the prototype drug. And it's very effective to treat UTIs, especially chronic type of UTI. Or it can also be used as a prophylaxis, like patients will tend to have a tendency to develop UTIs. Then we can prophylactically prescribe a lower dose, a small dosage of pure nitrofurantoin, macrodantin to treat, or macrobid to treat, to prevent the UTIs. The drug, which is phosphomycin manurol, that's the drug has been approved in 1996 and has been classified as a cell wall inhibitor, and it reaches the high concentration in the urine and the bladder. It's a bladder antiseptic. and it's a one single oral dose of the medication. That's increases the adherence and compliance with the drug regimen because that's only one single PO dose, phosphomycin, Manirol. No, nalidixic acid, Nigram, which is also a UTI or urinary tract antiseptic. Its relative of fluoroquinolones was the first quinolone anti-infective marketed historically. It inhibits the replication of the bacterial DNA and RNA. Possible that the resistant bacteria often emerge during treatment. And it's active against the most of the gram-negative UTI pathogens. The penem family, or the carbapenems, it's a beta-lactam antibiotics, have an extremely broad antimicrobial spectrum with low toxicity. Not effective. So the prototype drug for the carbapenems is the imipenem cilastatin, which is the Premaxin, which is brand name for the imipenem cilastatin. And we have another drug, which is meropenem, and under the same family, the carbapenems. So we because of the suffix penem, so that's the penem family. So the beta-lactam antibiotics, they have an extremely broad antimicrobial spectrum. And the great thing about this group of meds or classification medications is that it has a very low toxicity. So there are 4 groups of the carbapenems that are currently used in clinical practice. We have the imipenem, meropenem, and doripenem. And another one, which is the 4th one, which is the ertapenem, ERTAPENEM. So all these 4 drugs, they end with the suffix of PENEM, the penem. So all 4 carbapenems, they are broadly active against the most gram-positive, gram-negative, and aerobic organisms. None is active against the MRSA. So none of these drugs are good for MRSA or for VRE or so MRSA or VRE. The ertapenem, important. That's very important. That's the ERTApenem, ertapenem. Is a great drug against specific disease called aeruginosa and Acinetobacter, that the other 3 agents than the other 3 carbapenems, like the imipenem or meropenem or doripenem. So In other words, that just brief in this that the ertapenem, it has specific effectiveness against specific disease called P. aeruginosa, AERUGINOSA. The good thing about the ertapenem is it's prescribed once daily as a one daily dose. And all four agents, or for the carbapenems, they are typically administered intravenously. So they're all IV medications. There's no oral carbapenems that are currently available in the market. And all of the carbapenems, they can cause hypersensitivity reactions and IV site phlebitis at high plasma drug levels. That's when the carbapenem plasma drug level is high. That's when it may result in a cause that reaction or IV site phlebitis. Vancomycin. So one of the miscellaneous inhibitors of the bacterial protein synthesis is the vancomycin. Very important drug. It inhibits the cell wall synthesis. That's the mechanism of action. It's very effective against severe infections. It's very effective against the MRSA, C. diff, and we usually prescribe vancomycin to treat the oral dose for C. diff. That's when the metronidazole, which is a flagell, when we try flagell and we find it's ineffective. So when a flagell or metronidazole is ineffective, then the vancomycin will be the second choice for C. diff. Adverse effects, we have ototoxicity, and that's sometimes reversible. Other cases would be permanent. Depends on the dosage, the frequency, depends on the term of use. Is it long-term, short-term use? So the vancomycin could also result in a red man syndrome, renal failure, thrombophlebitis, very common, thrombocytopenia, not that common but rare compared to the thrombophlebitis. Thrombophlebitis is a very common side effect of vancomycin, but thrombocytopenia, low platelet count, may drop. Low platelet count, so platelet count may drop, but that's not common as the thrombophlebitis. And also, in addition to that side effect, also renal damage or renal failure. Now, the vancomycin is classified as stage 2 cell wall biosynthesis inhibitor. It kills bacteria and is thereafter labeled as a bactericidal agent. Due to its large molecular size and lipophilicity, vancomycin, that is able to dissolve in the the cell wall, which is full of lipids, the vancomycin is only effective against gram-positive bacteria. The drug's lipophilic characteristic allows the drug to diffuse through the highly lipophilic bacterial cell wall of the gram-positive organisms. So the gram-negative bacteria have membrane proteins called porins. So it's full. So the gram-negative, they have this. Their cell wall is full of proteins, not lipids, like the gram-positive bacteria. So that's why vancomycin is very effective, or only effective, against the gram-positive bacteria, because the drug has a large molecular size and it has a lipophilicity. In other words, that's the drug's lipophilic characteristic allows the drug to diffuse through the highly lipophilic bacterial cell wall of gram-positive organisms. That's why the vancomycin is very effective only against gram-positive bacteria. So the vancomycin is not good or ineffective for gram-negative bacteria. The aztreonam. The aztreonam, that's the only available monobactam drug. It's one of the monobactam drugs, and that's the only one available right now, the monobactam, which is called aztreonam. Now, the drug is very active against most gram-negative bacteria, including that disease called P. aeruginosa, or the type of bacteria is called P. aeruginosa, but it has no activity against the gram-positive organisms. And aztreonam also is particularly useful in patients with serious penicillin allergy. So patients with penicillin allergy, aztreonam is good drug or useful in those patients who have an allergy to penicillin, and patients who have infections due to resistant gram-negative organisms. So patients who have aztreonam is particularly useful in patients with serious penicillin allergy who have infections due to resistant gram-negative organisms because of its lack of cross-allergenicity from the allergen. So it has a lack cross-allergenicity with penicillins. Like the patients sometimes when they are allergic to one drug from the same classification might not be allergic to another drug from the same class. So because of so here we said that the aztreonam is useful in patients with serious penicillin allergy who have infections due to resistant gram-negative organisms because of its lack of cross-allergenicity with penicillins. That's what is called the cross-allergenicity, in terms of that becomes allergic. One drug from the same class may not be allergic to another drug from that class. However, the gram-negative bacteria with extended spectrum beta-lactamase, they are resistant to the drug. And the aztreonam is available as an parenteral IV intravenously for treatment of systemic infections. Also, it's available as an inhaled form of prevention of pulmonary exacerbation in patients with cystic fibrosis, especially patients with cystic fibrosis who are commonly colonized with P. aeruginosa, with that type of bacteria, or P. aeruginosa. So again, it is available as an intravenous drug for treatment of systemic infections and as an inhaled medication or form for prevention of pulmonary exacerbations in patients with cystic fibrosis. Those patients with cystic fibrosis, usually children who are commonly colonized with P. aeruginosa. Mongerol or fosfomycin, which has been approved for a single dose therapy of uncomplicated UTI caused by E. coli or Enterococcus fecalis. It disrupts the synthesis of the peptidoglycan polymer strands that compose the cell wall of the bacteria. Most side effects of the mongerol or the fosfomycin: diarrhea, headache, vaginitis, nausea. Linezolid, which is Zyvox, first member of a new class of antibiotics called oxazolidinones, and these medications are active against the multi-drug resistant gram-positive pathogens, like, for example, like the VRE, vancomycin resistant enterococci, or MRSA, methicillin resistant Staphylococcus aureus. It's a bacteriostatic inhibitor of protein synthesis. The cross resistance with other agents, it's unlikely, or it's very rare, not common to have a cross resistance with other agents. Active, that the Zyvox or linezolid is very active against the aerobic and the aerobic gram-positive bacteria, and very effective also for the VRE and MRSA. Most common side effects for linezolid Zyvox is nausea, vomiting, diarrhea, and headache. And the drug may also cause myelosuppression. And it has an interaction, or may interact with the monoamine oxidase inhibitors. Chloramphenicol. It's a broad spectrum antibiotic. It inhibits protein synthesis. It's only for life-threatening infections. So severe life-threatening infections, that's when we would prescribe chloramphenicol. And we will lean to prescribe from chloramphenicol when the safer drugs are ineffective or contraindicated. For example, can be prescribed for salmonella infections, typhoid fever. The adverse effects of the chloramphenicol, it's very severe, and it's detrimental effects and complications could result from the drug. That's why we don't usually recommend prescribing the drug unless it's the last resort, and it's when we find all other safer drugs are ineffective or are contraindicated, that's when we lean to prescribe the chloramphenicol. Chloramphenicol can result or lead to reversible bone marrow suppression or depression. It can lead to fatal aplastic anemia. It can lead to Gray syndrome, GRAY, Gray syndrome. That's when the liver becomes unable to metabolize or excrete the drug. There's also severe GI effects or symptoms, and also it may lead or cause the peripheral neuropathy. Clindamycin, it inhibits the protein synthesis. It can induce severe antibiotic-associated pseudomembranous colitis, and that can be fatal. It's very active. The drug's very active against the aerobic gram-positive and negative bacteria, anaerobic, and it's usually indicated only for certain anaerobic infections located outside the CNS, central nervous system. Acne vulgaris is one of the drugs or the indications for this drug, for clindamycin. Side effects may lead to antibiotic-associated pseudomembranous colitis, hepatic toxicity, blood dyscrasias, and severe anemia, diarrhea, and hypersensitivity reactions. Mupirocin or the Bactroban, Mupirocin, Bactroban, very effective ointment for the MRSA and the nostrils. Basetracin, it inhibits the cell wall synthesis. Basetracin available as the monotherapy, basetracin only, or sometimes we have it also combined with the other medications like polymyxin B, over the counter, the first aid product and on the OTC shelves being used, publicly used, because it has neosporin, has sporin, combined with the basetracin, so that comes in packets, small packets of ointment, and that's very effective as a first aid ointment. Topical application. The systemic toxicity that may result from the basetracin, that's why it just only has to be used topically, not for internal use, because it may result in nephrotoxicity, anaphylaxis, and other GI symptoms. We have daptomycin, polymyxin. Polymyxin B also, it should not be used for systemic infections because of the toxicity risk. Rifampin, we will revisit rifampin next in the fall under the TB medications, tuberculosis medications. Rifampin is one of the main 4 drugs that will treat patients with pulmonary TB. One of the known side effects of the rifampin is that's going to change the urine color to red, orange tinged color. Rifaximin, which is a Xivaxin. It's a tablet, non-absorbable form of rifampin. And usually it's prescribed, can be, we can prescribe that for travelers diarrhea, but also it's one of the very effective drugs being prescribed for patients with liver cirrhosis. Because the rifaximin or Xivaxin, it has a dual effect, 2 main effects. The first one is anti-infective characteristic, and it has also the ability to bind the ammonia in the GI tract and release it in the bowel movement. So instead of giving lactulose, because patients with the liver cirrhosis usually receive lactulose to lower and eliminate that ammonia being accumulating, which will accumulate in blood vessels, so it can be released through the bowel movement. So lactose has too many side effects that will make patients not, dislike it, not, compliant and not adherent with lactulose. It's a liquid form, has a very bitter taste, and should be taken several times, 4 or 5, 6 times a day. Patient would have more than 10 watery or loose stools in 24 hours, so that will prohibit patients from taking the lactulose. Xivax and rifaximin has the same effect of anti-infective, and also it lowers the ammonia level. But it's a tablet form, 1 tablet per day, and it doesn't have all of the lactulose side effects. That's why it's preferable drug among patients over the lactulose. But the problem is the price, very expensive, and some insurance companies do not cover the rifaximin or Xivaxin. Metronidazole, which is the flagell, very old drug, has been approved. It has a dual activity against both bacterial and multicellular parasite. It's a great drug, very effective for GI infections. Great for trichomoniasis, giardiasis, for giardia, for amoebiasis. So for all these GI infections is a very effective drug. H. pylori, also very effective for H. pylori.